Hello students, today we are going to go over our lecture on child and adolescent development. Remember that this is the first part of the lecture that is going to exclusively focus on child development, and the second part of the lecture will focus on adolescent health development. So again, what are we covering today? The lecture is on child development and our focus is on child's physical and cognitive developmental milestones. Here are some lecture objectives for you. We will basically be describing, or what I want you to do, is to be able to describe trends and major issues related to physical health during these ages and also in mental health. And I've also divided the developmental milestones from birth until age 4. I've also sort of organized them into 4 different categories. So these major developmental milestones can be divided into social, emotional, cognitive and mental, and physical categories. So let's look at our first age. I have divided them also into ages by 1 year, 2 years, 3 years, and 4 years, and with important highlights for each year. And physicians and medical professionals use these to evaluate the development of a child as per their age, and we also use them within the system to determine if a child is developing appropriately for his or her age, or if they're facing any kind of developmental delay. So looking at the first one, the 1-year milestones, I wanted to look at the 2-month and the 12-month milestones. When we look at the 2-month-old, you're making a baby laugh with silly faces and noises. The baby's smiling at people, so there's an exogenous response. There's also language development with the coos and the caws, where the baby is able to respond, and that is their way to respond back to you. They also have their favorite things, such as certain toys and blankets. There's also a parental preference between mom versus dad, with either parent, and that again comes with whoever is the primary caretaker for the child, and the child being more connected and bonded with that parent. The child is also able to follow and recognize people with eyes, so they're able to maintain eye contact. They're also able to do smooth movements with the hands, so the fine motor skill is really developing during this age, and their grasp really strengthens. So if you notice, compared from newborn to the 2-month age, the child is able to hold on to things, small, tiny things, but they're able to hold on to that, and their grasp is a lot more powerful compared to a newborn's. And when we jump forward to the 12-month age, during the 12-month milestones, the baby has developed significantly in all aspects. They're able to like favorite things and people. And there's this form of a likeness status that forms with familiar faces. So if you notice, when a 12-month-old child goes to a stranger, they're not really able to, or they feel anxious, they feel scared all of a sudden, and they express that through crying. As soon as they go to that familiar face, rather be a mom or dad or a relative, they start to feel much more calmer. So you have that likeness status for familiar faces. The child is also able to use language more eloquently, in the forms of, with motions of bye-bye and words like mama and dada, with enormous growths and improvement in that area. They're also able to follow simple directions. So their language is definitely advanced within this age. And they're also using simple words, like I said, and it could be, not just mama and dada. If they have a favorite food, milk, or anything like that, they'll be able to indicate that through language. Physically, they're able to do more as well. They can crawl, they may stand. And now, let's go ahead and look at developmental milestones for the first 2 years, or at the age of 2 years. At this point in time, the child is showing definitely a lot more independence, and resistance, and also some defiance. They're able to speak more, with about sentences, actually, with 2 to 4 words each. It is simpler sentences, but they're able to express a lot more language-wise. They're able to do more with their hands. They could, build blocks. They can feed themselves. They can try to clean themselves. Use paper towel, use toilet paper. They're also much more mobile. They're able to kick, they're able to run, they're able to run around. So the development of the intellectual abilities, we also see that happening in the 2-year milestones. So in the form of independence, in the form of, intellectual growth, engagement in social settings, engagement with peers, being able to express themselves. Throughout, though, is imagination and the use of imagination. You can see it when a child likes to hear stories, when they like to talk about, certain items with exaggerated stories. So although they're not able to express much, they're able to still show that usage of imagination, and that's developing. It's very critical at the 2-year milestones. At the age of 3 years, what I want you to notice is the child being able to use emotions in order to communicate. So one of those emotions is empathy, and being able to use it appropriately in a situation in order to communicate well, being able to listen and understand an individual, being able to comprehend appropriately with that. And at this point in time, they're able to talk well enough for strangers to understand. They're able to also further use your imagination in the place of make and believe. So the imagination is definitely getting stronger with scenarios and being able to talk about it and exaggerate those as well. They're also able to do more physically. So from being able to run around, they're able to climb now. They're able to walk well, really well at this age. They're able to run really well at this age. And overall, there is a continued growth of milestones and strengthening that have been developed in an earlier age, and that is something that often gets unnoticed, but it's very important that the milestones that have been developed in the previous ages, there should be no regression on those. They should be continued as the child grows older. At the age of 4 years, a child is able to do a lot more in all 4 aspects, in all 4 categories that we talked about in our earlier slides. So socially, they're able to actually enjoy a social play. They're able to communicate in it. They're able to understand exactly what's going on. They're able to tell stories of their own. So at this point in time, our imagination has definitely strengthened quite a bit, where we're not just using it to hear stories or talking about scenarios. We're able to tell stories of their own. They're also, and this is very critical, they're able to understand the concept of time and how it ties in with the value and the usage of time, being able to finish a task with a deadline. Physically, the child can definitely do a lot more. They can participate in sports now, for example, something very simple like being able to catch a ball. They're able to do more with their hands as far as arts and crafts is concerned, so they can cut with scissors. Sometimes the usage is not very good. They can cut their own hair. I've had that happen with my 3.5-year-old daughter, so we're definitely keeping the scissors away from her. Another thing that's very important is this concept of truth versus lying, and the child being able to understand when they tell a story or when they tell, when they say a statement, if that's a truth or if it's a lie, and being able to understand why one thing would be good versus bad. So again, I touched upon briefly earlier why understanding the milestones is very important, and it's important to be able to catch developmental delays early on in a child's life, so you can start the treatment early. Remember that early treatment is equivalent to a greater improvement. When the treatment is started later during a child's age, the scope for improvement is not so much over there. And we usually see developmental delays being tied with low birth weight, so babies that are born preterm, babies that have in families with this lower socioeconomic status, that also has an impact. We would like to believe that it doesn't, but unfortunately it does. And there are also other family variables that are involved, such as social support and maternal depression and things like that. So why understanding the milestone is very important. So frequent visits, if you notice, when a child is born, there are frequent visits with the primary doctor, and frequent questions that are asked about the child's growth and behavior, questionnaires and paperwork, and all of that is essentially done to gauge any kind of developmental delays that might be occurring. There's a hearing test that is performed when a child is born, just to make sure the child responds to hearing stimulus. And all of that is important, so if there is a developmental delay, it's detected early, so improvement could start early as well. When you wait too long, again, those improvement chances decreases. Another common example is autism spectrum disorder. When that's caught early in the childhood, between the ages of 1 to 4, there's a much greater chance of improvement. So why are we talking about all of this? Another important reason for making sure that this data making sure that those are occurring on time, is for public health data usage. Monitoring and reporting is also important for public health practice. All of these public health programs, public health interventions that are created that we often see through national agencies such as CDC or NIH, those are completely reliant on the data that is collected from patients, data that is collected in doctors' offices. One such example is this ages and stages questionnaire that is often given at doctors' offices to for newborns and to new parents. And I encourage you to click on those links and look at those questionnaires. There's one for parents, one for health professionals, teachers, and really goes on, what are some of the developmental milestones that should be occurring for each age. And if certain things are missing, what is the best way to take action? So it is one of the supplemental resources where I encourage you to take a look at it. It is great exposure. However, it's not something that I will, put on the exam. But you might want to know what is an example of a public health measure or public health practice as far as data collection is concerned for monitoring and evaluation. Now what I want to do is divide the lecture to focus on selected issues during the infancies and selected issues later in the lecture, selected issues during childhood. The issues that I want to focus during infancy are SIDS, sudden infant death syndrome, maternal postpartum depression, and the infant feeding habits. In this particular slide, you can see what I've done is all the data that I wanted to go over for SIDS, I've sort of compiled it into this one slide through this graph, which is really great because it gives us lots of good data. The chart here covers information from 1989 to 1998, and although it's a little dated, it gives us a good exposure of how SIDS cases are divided into different ethnicities and within different time periods. The graph also displays statistics based on the educational and the socioeconomic levels of the mother. If you look right here, it shows us that the cases of SIDS have decreased significantly, so that's a great thing, from 3.5 cases per 1,000 births in 1988 to 2 cases per 1,000 births in 1999. And that ratio has also gone down further as we speak right now. It also gives us information on the subgroups where you can see, if you notice right here, each key has been divided with different colors, and each color represents a different educational level of the mother. So this color right here is the mothers who gave birth who only had elementary school education. This one right here correlates with some high school education. So this one is elementary school education. This one is with some high school education. Over here are kids born to mothers who are high school graduate, some college, and then college graduate. And if you notice, there's a trend within each ethnicity that as the mother's educational level increases, the rate of SID within that group also decreases. The educational level definitely has a positive impact. And also we're looking at race and ethnicity and how that is tied in with this with the incidence rate for SIDS. So amongst all the groups, we do see that African American mothers who gave birth during high school has the highest rates for SIDS cases. It also indicates how socioeconomic status would be tied in with the race and ethnicity, which overall then determines the number of SIDS cases for each subgroup. And again, this is great exposure for how this data that is collected at doctors' offices can be put into a chart and be able to give you a complete picture of several decades of how a certain disease has gone down or has progressed during the years. Now let's look at postpartum depression, also known as PPD. Every year within the United States, about 10 to 15% of new mothers are diagnosed with postpartum depression. And globally, we still have a very consistent figure to about 10 to 20% of mothers. The postpartum depression is a little tricky. It could be present at birth. It could show up anytime up till the 12 months after delivery. It can even develop during pregnancies. And there's very specific risk factors that are involved with that. And we're going to talk about that. However, something to note is that postpartum depression is different from pregnancy, which, pregnancy blues, which eventually passes with time. And one of the biggest issues is this misdiagnosis of the postpartum depression with pregnancy blues. It is not the same symptoms of depression, and it is not very prolonged. Now let's look at some of the risk factors for PPD And although we have about 1, 2, 3, 4, 5 risk factors here that have been described in great detail, I would like for you to focus on these three: the socio-demographic parameters, family dynamics, medical illnesses, and pregnancy-related outcomes. Now, that is not to say that these two do not have any kind of impact or are not of any value. They're all of equivalent value, but just for this lecture, I would like to focus on these three risk factors. So if you look at, and pay close attention to the following. So if you look at the socio-demographic parameters, we're able to see how age, race, educational status, poverty, and socioeconomic status all play a role in creating that support system, that support network for the mother, through which she feels that she's able to take care of the child. And when those are not in place, that often becomes a contributing factor that often becomes a risk factor for the mother. We'll also want to look at the family dynamics, where there is a history of maternal and paternal, there's a history of marital domestic violence, poor relationship with the partner, or not having enough support from the husband, the family members. So again, going back to that support system, lack of knowledge or awareness about, the ups and downs within the mood, and the mother not being aware of those or not noting those. And also the birth of a girl child when a son was desired, so not having the desired gender of the child being born. All of these family dynamics are also very strong risk factors for the postpartum depression. And then the last one is the medical illness and pregnancy-related outcomes, where if there is a history of a pre-existing condition, or there's a history of depression before the pregnancy, that could definitely be a contributing factor towards this mental health problem as well. So all of those are contributing risk factors for postpartum depression. There's this really unique and a very interesting documentary on YouTube about zip code and how zip code determines destiny. And unfortunately, sometimes it does come into play where your lack of access to care is often decided by where you live and what resources you're surrounded by. And if you notice, in each one of these cases, not having that support system, not having that access to care, medical, dental, mental health, could definitely impact the mother's overall health status, and thus could contribute to her having postpartum depression. The most important risk factor that I consider for PPD is the lack of family and social support. And also if the mother is suffering from PPD, then it does impact the social, mental, and physical well-being of the infant. And there are two ways that they handle those. They can either externalize the behavior, or they could internalize the behavior. When a child externalizes a certain behavior, they're impacting others through it, and it's really visible to others. In children, we see it in the form of bullying. When a child internalizes behavior, it impacts their own mental health status, where they develop a lower self-esteem, so they're focusing inwards. There's a social withdrawal from group settings, from school, from social play. There's this feeling of loneliness, backed up by a feeling of unloved and being sad. What are some of the negative impacts on personal, family, and on the child's development? Many adolescents and adult mental health problems have originated during childhood, and that has been proven through research. In fact, it also impacts child's cognitive development and their behavioral disturbances, and that can get strengthened throughout the years. It can contribute to spousal relationships and to an overall quality of life, not just for the mother, but also for the child. It is important to note that if the mother went through any of these negative factors sometime in life, it could impact the development. Okay. So what is the main predictor of externalizing and internalizing behaviors in toddlers? The problems, they get amplified as well when the child grows older, unless it's treated right on time. So again, it ties back with our early detection, early detection, early treatment, that leads to greater improvement. And it may be accounted for by age, race, education, smoking, and relationship status. So our key is to center our postpartum care for the child and also for the mother to reduce postpartum depression. So right here, we look at some clear benefits versus no benefits of breastfeeding. You are able to see that breastfeeding helps decrease your infection incidence rates, helps decrease the rates of ear infections within the child. Some of the other things are such as obesity, type 1 and type 2 diabetes, cancer of breast and ovarian both for the mother, and maternal postpartum depression. So that ties in with what we just talked about earlier, that breastfeeding not only just helps the child but also the mother in not developing maternal postpartum depression. What is unclear, or benefits that are not so clear at this point, is osteoporosis and decreasing that risk within the mother, the return to pre-pregnancy weight for the mother, and a general weight loss. So, I mean, women from all over the world would like to believe that breastfeeding has helped reduce and aided in their weight loss, but that may not be the case because we still have not proved that through research. And we have several state and local initiatives that promote breastfeeding to the mother, because it's it's the nature's way of providing a cost-effective solution to postpartum depression, to child health, and to improving a child's immunity for all of these other infections that occur during the first year of life. However, we also need to look at alternative infant feeding. Breastfeeding may not be the feasible option. Although it may be the best option for the child, it may not be the best option for the mother. There could be medical conditions that may prevent the mother from doing so. So what do we do in that case? I'm glad for alternative infant feeding. And there are international codes of marketing breast milk substitutes or alternative substitutes that have been developed by the World Health Organization and the World Health Association. And there are two key purposes. The first one is to make sure that they do support breastfeeding, regardless of how good the alternative feeding is, but also to make sure that the substitutes are safer and they can be used when needed. And they do that by promoting two actions. The first one is through limiting sample distributions and financial incentives by formula brands, and then also by limiting marketing in the healthcare facilities, marketing of the formula brands in healthcare facilities. So I'm going to give you some examples. Range, goodies, labels to physician offices to support a certain drug brand, right? Similarly, within the hospitals and OB-GYN's office, they hand out feeding kits of leading brands to new mothers. So in their delivery unit, a new mom might get a feeding kit that would include formula, dry and liquid bottles, and things like that. And it might be a great gesture because it's, again, building the support system for the new mother if she's not able to breastfeed her child. However, it's all a part of a big marketing strategy, and patients may not realize that when they participate in that they're becoming a part of a marketing strategy. How does it impact the patient? Well, let's say if a mother does choose to continue with the formula and she's looking for the perfect formula brand for her child, and she's used the formula kit early on in the hospital or in her home, is she going to change that, or is she going to look for the exact same brand if that suits her child? She's going to look for the same one. So again, she is becoming part of that marketing tool and marketing strategy. And there have been recent improvements in the formula with the addition of DHA that was only previously found in breast milk. And DHA is this fatty acid that is in breast milk that babies can't make on their own, or the addition of optic growth factors that help support brain cell generation. And all of that, again, is to improve the quality of the formula and to make it equivalent to breast milk. But, still research says breastfeeding is the superior option if it is feasible for the mother and the child. We also want to look at some of the other issues in young childhood, such as obesity, oral health, and mental health. In this particular slide right here, we'll go over childhood obesity. And if you notice, health professionals, including doctors and public health professionals, they do say that we live in a century where chubby children may not be able to outlive their parents due to this decrease in life expectancy that we see for obese children. That comes in with the development of chronic diseases such as diabetes and high cholesterol at such an early age. And if you notice, a few decades ago, diabetes or high cholesterol within children was not necessarily the case, but that has become quite the norm in today's day and age. We do see this life expectancy decrease, and that's quite saddening because obesity is a completely preventable diseases. But unfortunately in the US, even if looking at adult obesity, it's the second largest behavior-related cause of death in US. First, of course, being smoking. And all of that definitely comes with a cost to the individual, to our healthcare system, the cost of the decreased life expectancy for the child, the loss of that potential for the child and for our society as well. In this graph right here, what I wanted to do is go over some data. And this graph, this chart is from 2012, and it basically goes over the percentage of children that are on the WIC program. Again, WIC is a national incentive program that provides supplemental nutrition for children that belong to a certain income bracket. So this particular graph focuses on children who are 2 to 4 years of age who have an overweight classification and they are on the WIC program. If you notice, there are 4 states with greater than 18%. Fortunately, Texas is not the most overweight state. Texas and other 22 are within the 16 to 18% classification, where 16 to 18% of children are overweight, those that are on the WIC program. In the second one, it talks about, it is the same ratio. The only difference is now those children who are obese. And fortunately, again, Texas is not the most overweight state and the not most obese state. There are 10 states that have greater than 16% of childhood obesity. This data is from 2012. There's definitely been changes. You know, food choices are changing rapidly, and thus there is an increase of childhood obesity that we do see within the state of Texas. Also, it is to note that this data only comprises of children who are on the WIC program. What about those kids that are not on the WIC program? So we definitely do see changes there as well, where Texas has increasing rates of childhood obesity. This particular slide sums up all of the impacts on the body systems of childhood obesity really well. It talks about neurological, cardiovascular, musculoskeletal. So it's a really great way to sum up how exactly does childhood obesity impact a child medically, and what are some of the diagnoses. So check out this video as well. Let's look at some of the risk factors for obesity.